Firstly, let me just say that it's absolutely a pleasure to be here. And nothing gives me a greater pleasure than Narendra Khanna, in association with Dr. Henry, having organized the National Workshop on Peripheral Vascular Intervention. And it gives me great pleasure. The reason for that is because, firstly, I've been a great fan of Dr. Henry for many years, great friend, and it also gives me great joy when I see Narendra actually leading the world in peripheral vascular intervention, because it was with me that he actually showed his interest in peripheral vascular intervention, and I then sent him to Michelle many years ago to actually train in peripheral vascular intervention. And therefore, it is just one of those days where I get very happy to see some of my own colleagues do so well. The second aspect is that I'm going to talk to you about renal artery stenting. Renal artery stenting is practiced by practically everybody who can lay his hands on a catheter, wire, and a balloon. Because all of us have got so used to fly-by angiograms without realizing the implications of these techniques, without realizing the harm that it causes to the patients, and without realizing that unless, just like the panel here, we're emphasizing the fact that it's more to do with the technique than anything else, it actually becomes very important to be very meticulous about renal artery stenting. In fact, almost all of us sitting in this audience, and practically across the country, I don't know of any interventionalist who doesn't do renal artery stenting. But rarely do we understand the indications, rarely do we judge our results, and for us, an angiographically dilated renal artery seems to be the end of the procedure without actually realizing the consequences of that patient, what could happen to him exactly 4 to 6 weeks later when he's actually having his dialysis, just because we didn't do the renal procedure properly. Because we don't see that patient, we're very happy that he's gone out of the hospital with an open renal artery. So I'm going to just take you through very simple points. Perhaps many of you practice it, but perhaps many of you don't even give importance to these, but they are very important. I believe that they're far more important than distal protection devices in renal artery stenting. So let's go through the fact that, we always do these flyby angiograms of renal arteries. We have to understand that why are we doing it? There's a hypertensive population of patients, but when there is coronary artery disease and there is hypertension, we have anywhere between a 5 and 15% chance of having renal artery stenosis, depending upon the published data. And the more the degree of atherosclerosis in the coronary arterial tree, the greater the chances of finding renal artery stenosis. But just finding it is not the issue. The issue is who are the potential people who can benefit from it. And that is not necessarily the task of my lecture to talk to you about who are potentially the people who can benefit from it, because out here on the panel are nephrologists and interventional cardiologists and vascular specialists. And each of us is going to have a different opinion based on which data we actually want to demonstrate to you as to what the benefits of renal artery stenting are. So I'm not going to take you through a whole roll of 3-hour discussion on this. Believe you me, our data is like cows. The more you milk them, the more you'll get milk. And so you sometimes really don't know what you're actually getting. Let me just go on to important issues. Certainly, I think the Duplé criteria of renal to aortic ratio is an important aspect. Certainly, I believe that in my practice, if I was to be ethical in what I was doing, I would use this criteria for deciding which patients to actually perform renal artery stenting. There's no doubt the other criteria do exist. If you got let's not forget those patients with flash pulmonary edema. Let's not forget those patients with intractable, unstable anginas. Let's not forget the patients who are on inadequately controlled hypertension despite more than 3 antihypertensive drugs. But we have to start getting away from an ocular stenotic reflux for renal artery stenosis in a very dissimilar manner when we talk about coronary artery disease. I can still accept ocular stenotic reflux in coronary artery disease, but I cannot accept that for renal artery stenosis. Now, 4 aspects of renal artery stenting is first the visualization, secondly the intubation, third is the dilatation and stenting, and fourth is the final result, the final angiographic result. And everything revolves around all this. So what do we mean by getting best angiographic results? The axiom, the corollary for everything, the rules of the game are, please do not scrape the aorta for locating renal arteries. Practically everybody does it. But you just need that one case of a paraplegia. You just need that one case of a distal embolization, of a gangrene in the toe to make you realize that these atheromatous aortas are disasters in themselves. If you actually saw any of these post-mortem aortas, you would be worried as to even put any wires and balloons in those aortas. And I think it's best not to scrape down these renal the aorta to locate renal arteries. The first should be an aortogram, a descending aortogram. If you have a DSA, use a DSA, but locate the renal arteries as non-traumatically as possible. And then you go and intubate them. So that is the first important point that I will always have a message. The second issue is the guiding catheters. We have the RDC guiding catheters in 7 and 6 Frenches, and most of the devices go through the 6 and 7 Frenches RDC catheters. But remember that in enlarged aortas or in smaller aortas and in diffusely deranged aortas, the RDC catheters do not intubate the renal ostium very well. And what may be an atraumatic ostium intubation is your right coronary artery guiding catheters. So do not discard your right coronary artery guiding catheters just because there is a renal guiding catheter available. Absolutely not. In fact, you perhaps a safer intubation with your right coronary artery guiding catheters. The only issue you should have in mind is the length of the stent shafts, always in your mind. So if you have stent shafts of 80 centimeters, be sure that you have to use an RDC. But if you have stent shafts of 130 to 140 centimeters, and I'll take you through that, that's when you start using your right coronary guiding catheters. It does mean that you have a long length of guiding catheter on your table. It does mean that you're actually working from a distance, but sometimes intubation is far less traumatic and embolization may decrease in those issues, especially of diffusely diseased atherosclerotic aortas. The third issue is the intubation of these guiding catheters. The important aspect is that the devices have actually changed dramatically over the last 10 to 15 years. And I think it's for us to realize that in itself, the devices, the stent, the balloon platforms are becoming smaller and smaller, compatible with O14 wires, so that they are able to track and able to cross with least disturbance to the plaque. And that has been the developments over the past 10 to 15 years. So instead of 8 French guiding catheters we were used to using 10 years ago, we're now down to 6 French guiding catheters. We've got O14 compatible systems with much lower profile, and they are actually now coming in either stainless steel, cobalt chromium, and even drug-eluting platforms. If I was to tell you that that each of these companies, Codex has its Genesis, comes in both 80 centimeters as well as 135 centimeters length. It comes in a variety of sizes ranging from 4 millimeters to 7 millimeters, and comes in a variety of lengths ranging from 12 to 18 millimeters, compatible with an O14 catheters. We have Medtronic Racer, which is a cobalt chromium, again comes with a 140 centimeter shaft. So you can even have longer stent shafts to be able to deliver stents even through normal guiding catheters. And again, these come in various platforms. And there are other companies which make similar stents, and there is practically, say Abbott makes the Herculic Plus, very little to choose in terms of stents. Whether cobalt chromium adds any advantage over a stainless steel platform, probably none, but certainly the profile of a cobalt chromium stent is lower than the stainless steel stent. So faced with a difficult situation, faced with an angulation, faced with a downward angulation, one actually adheres to the cobalt chromium platform, which are more trackable than the stainless steel platform. Third issue is the wires. Most of our wires, which we use for coronaries at the moment, are support wires. Very advantageous to use support wires because a downward pointing renal artery straightens up with our support wires very easily to be able to deploy stents easily. So it's important that as we go along, our wiring of downward pointing renal arteries relies on more and more support wires, which are nice, which are slippery, and yet provide great strength in crossing sometimes very heavily calcified osteas. Remember that the guiding catheter does not provide support in terms of renal artery stenting. It is your wire and it is your crossing the ostia, which is the most important aspect of renal artery stenting. I've taken you through many of the stents and the newer designs I would talk about. Yeah, an LA of 30 degrees probably gives you the best projection for the osteas of the renal arteries. But one of the best ways to know where the ostia lies is 3 aspects, which I always do. Firstly, with the balloon inflated in the ostia, rotate your angulation to see which is the maximum length of the balloon you actually see. That actually tells you the best projection for that particular ostia. And as you know, 90% of our lesions are osteal lesions we treat. That is the best way for you to judge the projection, which actually shows you the ostia. The second issue is that as you inflate the balloon, make sure that you actually record the indentation of the balloon at the ostia, because that is your landmark for placing renal artery stents. Never, never rely on guiding catheter injections repeatedly, because you're going to fill the patient with contrast in trying to make sure your position of your stent to the ostia is correct. But certainly rely on the indentation you create in the balloon. Put that as your landmark. Put that as your roadmap to be able to deploy your stent properly. And that is the projection then you use for deploying the stent. Of course, one uses panoramic view, and then you move off to the fact that we know that we've already discussed it. Hydration for these patients is very important, perhaps the most important aspect. We actually definitely rely on one fact that we use Visipaque, Adixanol in these patients. Hexabrix is another good contrast which one can use. Isoosmolar and ionic. Sodium bicarbonate has been proven to be of benefits, but very few of us rely on these patients who are not renally compromised to actually use sodium bicarbonate in these patients. Hydration, I would still say, and meticulous technique is still the best. But do not forget to stop or decrease antihypertensive treatment prior to renal artery stenting. You have those patients who are fully loaded with antihypertensives, and soon after renal artery stenting drop their blood pressures dramatically, making you flurry in all sorts of directions, trying to locate bleeds, trying to locate other aspects, and all that has happened is that they've been overloaded with the antihypertensives. So optimal technique. Here is the dilatation part of the issue. Of course, we understand that one underdilates the osteal lesion, trying to make sure that you have at least distal embolization as possible. In my mind, this is almost like dealing with vein grafts. Except in vein grafts, you have slow flow. In renal arteries, you don't see the slow flow. But I agree with Michel that there is a lot of distal embolization happening. And because we're treating a lot of patients who've got normal renal function and normal GFRs, we're probably not seeing them going into any obvious renal failure. But if we did their GFRs sequentially, we would actually perhaps see a drop, which may recover over a period of time, but we would see a drop. But I have had those very patients who've actually gone into renal failure following a renal angioplasty at 6 to 8 weeks' time. And that is truly to see a patient on dialysis who was never on dialysis, who was never expected to be on dialysis, and all you did was, in a space of a renal dysfunction, stented his renal artery. It is sometimes disturbing. Now, in a heavily diseased aorta, in a heavily diseased ostium, in a very atherosclerotic aorta, consider going from the brachial, which is very important, because you do not, then you have a straightforward chance of a very coaxial approach to renal arteries. But those are perhaps the only patients with the downward pointing aorta renal arteries that I would say that brachial artery would actually be the alternative to femoral approaches. Otherwise, 97% of the patients you can actually access through the femoral approach. The no-touch technique is important. The importance of that is that you dilate. In the past, when we had poor devices, when we had poor trackable, high-profile stents, we always had the issue about soon after deflation of actually pushing our guiding catheter over the balloon, using the balloon as a front to actually deep throat the guiding catheter across the lesion into the renal artery so that we could bypass the aorta ostium and therefore implant a stent which would not get stuck in the ostium, using the guiding catheter almost like a sheath. An extremely awful and a bad technique to have actually practiced for many years in the days of high-profile stents. But with the present low-profile stents, the whole issue is stay as much out of the ostium with your guiding catheter as you can. Do not even try to intubate your guiding catheter into an ostially diseased renal arteries. Your dilatation should be adequate, your support wire should be adequate, and your choice of stents should be adequate enough to cross smoothly across the dilated lesion to be placed across the ostium. And that, I must say, is perhaps my biggest important message. Do not shove your guiding catheters into the ostias. And of course, one knows that that is what is the whole issue about embolization. Perhaps greater embolization comes when we actually traumatize the ostias with guiding catheters. And if we are meticulous with our implantation, the reason we get away with so many renal angioplasties without raising creatinines, without using distal protection, is perhaps those issues. As one puts in the stent, there's always the practice of making sure. We always worried about choice of size of stents. We always worried about what size of stents to deploy into renal arteries. We are sometimes worried about being undersized versus oversized. And believe you me, oversizing. Do not oversize in a renal artery. Renal arteries are prone to rupture. Renal arteries are prone to rupture right at their ostias, and the catastrophic consequences of renal perforations are catastrophic. I actually rely on undersizing very commonly. I would prefer to go into every renal artery, usually with a 6 millimeter stent. I would use my 3.5 millimeter pre-dilatation balloon as a marker to guide me whether a 6 millimeter stent would be quite okay. I would actually go up with a 6 millimeter stent to its full maximal. And remember that we're not looking for a 0% stenosis as we do look for in coronary arteries. Having said that, there is been clear-cut correlation of residual stenosis with restenosis even in renal arteries. But safety on renal arteries is a very important issue. We're using large stents, and at the end of the day, we are not looking for a 0% residual stenosis in renal arteries, which, in the face of an ostial calcified lesion with bulky plaque, you try and get it to 0, you either have a perforation or extreme degree of distal embolization. Philosophy here is get a good result with a less than 20% residual stenosis is all that we require. We are always concerned about how much of stent to actually project into the aorta. Remember, aorta projection of stents into the aorta is not an issue. Be sure not to miss the ostium. That is the bigger issue. The stents are large and they foreshorten. There is going to be at least 1 or 2 millimeters of foreshortening and therefore have adequate amount of stent. Remember that it's the lower edge of that renal artery which is your landmark, not the upper edge of the renal artery. And when you actually make sure that you're at the lower edge or before the lower edge, your stent is going to protrude anyway into the aorta because the upper edge is way inside your lower edge. These are not the issues. Nothing entraps. Nothing ever happens to these stents unless you pull them out or you yank or your wire gets entrapped into one of the stent struts. So the issue is cover the ostia completely. We talk about flaring of the stents all the time. There is still no data and no importance of flaring of those stents as you come out and expand them to high pressures. The issue is not the flaring. The issue is that the ostia need higher pressures than the distal. And the distal point where the stent goes in is not diseased, and therefore that can be deployed at lower pressures, but your ostia need higher pressures. And that is where the whole issue lies. So my philosophy about coming back and doing a high pressure inflation is to get the ostia expanded. I'm not worried about flaring the stent, so there, please deviate away from pushing the catheter up and pushing the catheter down and getting all sorts of angulations to start flaring those stents. The only importance perhaps of flaring the stents is the fact that you move them away from the large internal lumen, so that in future when you're passing up wires or balloons or catheters, you don't want to get entangled in those devices. And that only happens if you've got a whole load of stent protruding outside. Finally, what do you do? Very important, and I think perhaps the most important thing in my mind is use your best projection and use a DSA, if possible, to make sure that you haven't had a perforation. Where are the perforations likely to be? Remember that there are two sites of perforations which are most important. Right at the point you deployed the stent and right at the periphery where your wire was. Those are the two important aspects, and never miss them out. So before you take the wire out, your contrast injections should show right to the periphery and should show you right at the point, studied carefully, because in renal arteries, once you withdraw the wire out and notice a perforation later, you are stuck. You are in a big mess, because your guiding catheter is not going to intubate that protruding stent very easily. Your wires subsequently are going through the stent struts, and you may actually spend a long time trying to get your guiding catheter and wire back to actually seal up a perforation. And this wire could be going through any of the stent struts. And when you dilate, your balloons will go through the stent struts, because these are large stent struts, and you will then realize that you've dilated a portion of the stent, crushed a portion of the stent. You'll get into a bigger mess. So never ever remove a wire till you are totally satisfied on all your projections that there is no perforation. And your final shot, of course, is then your final shot, making sure the periphery as well as the renals are okay. You have the occasional issue about not being able to intubate a renal artery. You can actually use the mother and child catheter, use the renal artery catheter over a RDC. You have 4 French right coronary artery catheters. One can use that. The downward pointing right, which become very difficult to wire, use a slippery wire to actually wire those. But make sure that your slippery wires do not go to the periphery. That is the biggest important issue I have to tell you about slippery wires. Good for crossing the stenosis, good for providing you support, good for going downward pointing renal arteries, but excellent for perforation distally in the cortex. So be careful about slippery wires. Keep in mind very few, this is coming to my last slides. There is no question that we should not forget renal artery stenosis for intractable anginas, as was in this 85-year-old patient with all occluded grafts who had a renal artery stenosis which improved after angioplasty. A clear-cut indication, always look for renal artery stenosis in patients with intractable coronary artery disease, especially if they've got very severe multi-vessel long-standing coronary artery disease. Renal function deterioration after initiation of ACE inhibitors is another. And you know, after initiation of ACE inhibitors, there is going to be a deterioration in renal function in all patients. But we expect a renal deterioration up to 2.5 millimeters of creatinine if there's already a pre-existing renal dysfunction. But anything beyond that must make you suspect of renal artery stenosis, and that could be one of the indications for actually renal artery stenting. We have the patients with flash pulmonary edema. We often attribute these to diastolic dysfunction in patients who've got no coronary artery disease and a normal renal function, a normal LV function. And every elderly patient has diastolic dysfunction, but do not forget that these patients could actually have renal artery stenosis and bilateral renal artery stenosis. We have patients with deteriorating renal function in whom one can actually stop the deterioration in renal function, especially if they've got poorly functioning, if they've got a single functioning kidney. So I think those are the issues in my mind about renal artery stenting in practical terms. Oh yeah, there are the issues about, yes, I've already told you about the brachial approach, very useful, must keep in mind for all difficult renal arteries. We're going on forwards, of course, to the fact that we have a role for drug-eluting stents, and trials have been done for sirolimus-eluting stents in renal arteries. I've regularly used for restenosis in renal arteries 4 millimeters taxuses, blown up to 4.5 to close to 5 millimeters for restenosis, and they've worked extremely well. We have now radiation balloons for restenosis in renal arteries, and of course special renal artery stents, which are more reinforced at the ostium, like the Abbott stent, which has got an ostial part which is more reinforced to be able to actually have less recoil. And of course, new flared stents are also coming out, which actually have balloons with stents, a combination system which actually helps you to trumpet the stents in a manner that the ostial plaque is plastered as you implant a stent into the ostium. And that is under trials at the moment. So we have new directions for the future. I think protection devices have been discussed. The controversy has been discussed on the table, so we won't go through the protection devices. That, in a sense, is the tips and trips about renal artery stenting. If I was to talk to you about celiac access stenting, I actually missed out that presentation because I didn't read the presentation, but the philosophy is simple. These vessels are between 7 and 9 millimeters. They would do well with balloon expandable, but they do best. We've discussed SMA stenting. I do those through brachials invariably. That is the best way to approach them. That is the best way to actually stent them. That is the best way to see the results. The ostials can still be done through a brachial approach. The Cobra catheter and intubates them very well. Your right coronary artery guided catheter can be sleeved over anything and stents implanted. However, and they are easier than the SMAs because they are less right-angled in the initial portion where they are straighter. But if you've got to do any intervention down into the celiac trunk, it invariably means that it is better to do it through the brachial. Ostias can be done extremely well through the femorals. Thank you very much for your kind attention.
Good point. There are a lot of points in renal stenting to avoid complication. Yes, thank you.
Ashok, what do you think, even if the renal artery sometimes is 4 mm diameter, my strong feeling is we should never use coronary stents. It's just that the radial strength that the renal stents have, the coronaries can never match, and we should never ever put coronary into a renal position. So what do you feel about that?
I think you raised a very important issue. Perhaps none of us knows the answer to that apart from deciphering from a common sense. You're right about the common sense part of it. These are ostias, and they're bulky ostias, and they behave very differently. Aortic ostias are different. They do require a better radial strength than we find in coronary stents. And for the reasons of radial strength, one believes that our peripheral stents are far more rigid and support the ostia very well. I'm not sure whether there are differences in that issue, but that is, in my mind, would be the biggest reason to use a renal stent rather than a coronary stent. Is there any other issues in your mind?
What about bifurcation? I mean, there were at least 3 cases in my practice where I had to use coronary kind of bifurcation and put in 2 stents. So does it happen often or?
Yep. You know, early bifurcations are an issue. Luckily, because you're right. But Hirmat, if you actually see how much renal artery stenting you do, and you see that occasional patient, renal bifurcation needing a stent. I do balloon dilatations. I probably don't stent the bifurcation. I always make sure that I can wire them and balloon dilate them, which is very simple through a renal artery stenting. But I rarely ever put a stent into the bifurcation. So these are actually making sure that we don't leave behind a branch stenosis or perhaps bigger issue. Remember, the branches are not diseased branches. Most of our ostias are the ones which are diseased. Occasionally you have that very early bifurcation where the disease processes goes into both. Perhaps those are the ones you're actually looking at in doing stenting. And I think those are those few demonstration cases.
Compliments, Dr. Seth, for Dr. Tyagi this side. Compliments, Dr. Seth, for demonstrating that no-touch technique and minimally invasive technique is the best approach to minimize the complications in this. One should also remember that one should use the least amount of contrast, particularly in patients who have these borderline renal functions. And in patients who have bilateral renal artery stenosis, one may stage the procedure. Do one renal artery at one setting, and to minimize the amount of contrast, as the patient recovers, one can do the second atherosclerotic renal artery in the next setting. And patients with fibromuscular dysplasia do not need stent implantation, that particularly in these patients who are young, and the results of renal angioplasty in them are excellent. The improvement in blood pressure is remarkable. In those patients who have atherosclerotic renal artery stenosis, the improvement in blood pressure occurs, but normalization of blood pressure is rare. About only 5 to 10% of patients have normalization of blood pressure. Rest of the patients require antihypertensive medications.
A very relevant point about contrast. I just want to, the restenosis within renal arteries is certainly a different aspect of things. I have more recently tended to use drug-eluting stents for those restenosis. Keeping in mind that these are 6 and 7 millimeter arteries and the restenosis happens, and the fact that the coronary stents can only be expanded to 4.5, and if you push yourself to 5 millimeters, I'm still of the philosophy that all that fibrous tissue, it's still not a malapposition of these 4 and 4.5 and 5 millimeter stents, because what you're doing is compressing them against a fibrous tissue. The original lumen is much more down. And in that 5 millimeter lumen, I believe that a drug-eluting stent can actually prevent a restenosis of a renal artery. I would just like that discussion to also happen, so that a philosophy about restenosis within renal arteries can be looked at in the present day of management rather than in the past.
I think for restenosis, our philosophy is to do cutting balloon angioplasty, because most of the time it obviates the need of stent, and the lesion that we get, the result that we get is excellent. Most of the time there is no dissection, but in case there is recurrence of stenosis, certainly drug-eluting stent, because these are 6 millimeter arteries. So if restenosis develops, one can certainly implant a drug-eluting stent. We have implanted drug-eluting stent, particularly in children who have arteries around 4 millimeter size, to reduce the restenosis. When dissection occurs, then we tend to implant drug-eluting stent in most of these patients. But initially we tend to use cutting balloon.
Yeah, even in the 6 millimeter arteries, one can implant these 4.5 drug-eluting stents, because you're actually compressing them against a fibrous plaque, fibrosis.
Absolutely.
You would agree that that was a brilliant talk by Dr. Seth. It was a pre-lunch treat, and he's emphasized very well that the benefits of renal artery stenting must outweigh the risks. And we must judiciously and very carefully, use stenting or angioplasty or whatever only in intractable hypertension when the patient is on 3 or 4 more drugs, and when we feel that there is definitely going to be an improvement in renal function. So that judgment has to be made by us, and definitely at least I don't know about foreign patients, but Indian patients are not going to spare us if they were not on dialysis and they're pushed onto dialysis after a renal stenting or any procedure. So careful evaluation of patients is mandatory. Dr. Seth has very well emphasized this point, and this would be the take-home message.
The 20% of the patients who are having deterioration of renal functions and on dialysis. Now, how can we assess these patients? That is the key question today. What is that subset we should avoid renal angioplasty? Now, to our experience, what we are having, we have found 5-6 points which we follow. That is one, as of we know the serum creatinine, if it is less than 2.5 or so, we are safe, to some extent. Though the GFR is more better. That is first. The second, even in that subset, if our patient is having hypertension which is recently coming, you are following the patient in OPD. Today you are using the blood pressure is 1 drug and the second day is the 3 drug. Then these are the patients who can be benefited. If your renal parameter, suppose creatinine is today 1.4, and you find that the parameter is going 2.5 or 3, these are the patients. If you are giving AC inhibitors, any AC inhibitors can reduce the GFR, and there is an increase in serum creatinine. But if it is persistent, if it is more than 25 to 30% increase in creatinine after using AC inhibitors, these are the patients who can be benefited. You see the size of the kidney. If the size of the kidney is less than 8 centimeter, these are not the patients who may be benefited. If, after all, you are not able to judge, patient is having borderline renal function, even you can go for kidney biopsy if the size is good, and then decide which patient. That is how you can reduce the risk, and that is the very important key factor to decide, rather than technicalities and other things.